Hi, my name is Emily, and I make videos about what it's like to be a mental health nurse. If you've been following my channel, I've been making some videos about inpatient unit nursing, and today I want to talk about my new position, which is as a care manager in primary care mental health integration. When I was in school, I didn't even know what was available for nurses that wanted to work in mental health. We did clinicals on the inpatient unit, so I had an idea about that. A lot of times, nurses are hired right out of school into inpatient, so that was just a natural progression for me, and I learned a whole bunch and got to do groups, and it was really amazing. But when I heard about this opportunity come up, I was really intrigued, and I had been feeling like I'd been wanting to move away from the 12-hour shifts, and kind of the very on your feet, go, go, go atmosphere of the inpatient unit. And so this position was totally telehealth. It was working with patients over the phone or via video, but it was still mental health nursing. So I was definitely curious, and luckily I got the position. I've been working there 3 months now. It has been so different from inpatient. First of all, just the acuity level of the patients. If you think about different levels of care for mental health, like you can think of it down here is like primary care. These patients might be prescribed a first line antidepressant, or they want to do some short term talk therapy with a psychologist, and that can be managed with the folks at the primary care level, because primary care at my hospital has some dedicated psychiatrists. There is nurse practitioners that specialize in mental health, and there are psychologists and social workers that can do short-term therapy like cognitive behavioral therapy, and that can all be just addressed at the primary care level. And then you got above that would be the mental health clinic, and that's going to be for folks that are a little bit needing a little bit more checking in. Maybe they're on a complicated array of medication, or just sometimes certain diagnoses they need to be addressed at the mental health clinic. That would be things like schizophrenia, bipolar disorder, severe depression that was not treated with maybe first line antidepressants and need ECT, which is the electroconvulsive therapy. But that kind of level of care. You got your psychiatrists working there, your nurse practitioners, maybe PAs, and then you have RNs who are care managers who are helping, like it says, manage the care for those patients. And that's another position that nurses can have. That is going to be, those nurses are going to see patients in person and also follow up over the phone to make sure things are going okay with the medication or whatever. There's also going to be therapists available at that level. And then above that is going to be the inpatient unit, and that is where I worked. These are the folks that are in crisis. Many of them have been put on Baker Acts because they're either a threat to themselves or others, or there's sometimes people who are detoxing from drugs or alcohol that just need that like very high level of care, and just watched and being very careful as they're detoxing. So I worked on the inpatient unit for 2 years, and just the environment, there isn't a lot of privacy for nurses to be able to take like a minute to themselves to really just like relax. I know that this is like an ongoing project that I know a nurse who's very passionate about a project to make a relax room, and this is being trialed on some of the med surg floors to make a relax space for nurses to come and decompress. But in my experience over the last 2 years, that was very hard to do. You can like go in the bathroom or something to take a minute, and also just the way that the inpatient unit's set up structurally, there's nurses stations that are all open windows so that the nurses can keep an eye on what's going on in the unit, so that to keep things safe. And there's patients, and there's techs, nursing assistants, and there's nurses, and there's management, and then you got your pharmacists and your psychiatrists and your residents and your social workers, and they're all just coming in. And one thing I realized in the 2 years that I that I worked there is that I'm a lot more introverted than I even knew. I won't say that it like pushed me to be an introvert, but it definitely like made me realize that how much it's just so draining to just like constantly being around a lot of people, because when I'm with somebody, I want to engage, and I just feel so drained by the end of the day being an introvert. So my new position is kind of an introvert's dream, in that I have my own space. It's a cubicle. But the walls are very high, and there's actually a door on it. So I can, between seeing patients, which is all, again, I don't know if I mentioned this already, over the phone or via video, I can take a minute to myself and breathe, and before I see the next person. I can also schedule my appointments myself, and I can schedule around other important meetings, or like if there's if I'm interested in taking a webinar that's an hour, I have flexibility where I can do that, where I can schedule my patients around that. The caveat is that, we're expected to do a certain amount of workload. So for my position, which is being a care manager at the primary care mental health level, I'm expected to do 6 to 8 measurement-based assessments a day. So what is a measurement-based assessment? That is done through a certain program that when I speak with a patient, if I assess if the medication is working or if they're having any side effects, I plug that into like a standardized question that is provided to me. Or if I'm assessing the severity of their depression symptoms, or their anxiety symptoms, or their insomnia symptoms, or their chronic pain symptoms, or whatever, the program gives me these standardized questions that I'm to use to make that assessment. And what's really cool about these MBAs, that they're called, these measurement-based assessments, is that because it's the same questions that I can ask the patient over time, typically I should call or check in with the patient every 3 weeks at least, for this block of time when they're initiating care with a new medication and or with therapy, to see how they're doing. But again, with the if they're actually initiating medication, I don't wait 3 weeks. I would call them at probably once they got it, I would call them within 7 to 10 days, and then again maybe a week after that before I would do the 3 weeks, because that's like the typical time when a side effect might show up, and so we want to catch that. But the measurement-based assessments are really neat because they will score the patient on the severity of their symptoms, and then we can track over time. And I've had a lot of patients really like this. Some of them don't like it. They're like, why are you asking me these same dumb questions? But some of them really like to hear their score. And I'll give you an example of say for depression. That assessment is 9 questions long, and it's rating for how often the person has experienced a symptom of depression, and each question asks about a different symptom. So question number 1 on that one is, how often in the last 2 weeks have you been bothered by having little interest or pleasure in doing things? And the answer choices would be not at all, several days, more than half the days, or nearly every day. And if they said not at all, they would get a 0, and it would go up. They would get a point for each one. And if it was nearly every day, they would get 3 points. So at the end of that assessment for depression, it's 9 questions. They could get up to 27 points, and that would rate them into different categories of either like mild, moderate, severe, symptoms. And that's I do these assessments, and often the prescriber, so either the nurse practitioner or the psychiatrist, look at those assessments, and that's how they decide, possibly what medication, because it asks about sleep, it asks about mood, it asks about anxiety versus depression, and so they look at what I'm doing on these assessments to help them decide what medication to try with this person. So it's pretty cool. It's pretty neat. It's really needed. Catching side effects, educating, just being there for somebody as they're going through, they're struggling with their mental health. It's all really important stuff. My favorite part that I get to do is help people with SMART goals. And that is something that I think of it as more like nurse coaching. And that is the thing that really lights me up, is like when somebody makes a goal, and we set a goal with each other, and I check back in, and they're getting better, and or a lot of people maybe just don't have somebody that really checks in with them about things like that. Like some of our patients live alone, and they may not have a lot of interactions with people. Like some of them might have PTSD, and they really just avoid people. So to have somebody checking in with them regularly and showing that they care, I think makes a huge difference. So I think I said basically the bulk of what I do. And if you have any questions or comments, please leave them below. If you are someone who's interested in mental health nursing, I can just say that there's more positions or ways to be a nurse in the mental health field than I realized. I didn't even know this position was a thing when I was in school. So I definitely am super happy that I chose the mental health route. That I knew that was for me when I was in school. And I'm really grateful for this job, because I feel like I like the shorter days, the 8-hour days, and I like, being able to be like a coach, and I like doing this work that really makes a difference in people's lives, and getting to show I care and connect with them and follow up. So thank you again for watching, and I look forward to making another video in the future. Let me know if you have any questions or comments. Namaste.